in this time. Right now we have to start about this particular nasopharynx. Okay. Very good morning to all. I have been telling about this carcinomas in the last few days. So right now we are there for discussion of nasopharyngeal carcinoma, which is very important as far as the exam point of view is concerned, and also anatomical understanding also very important. So I hope you are able to see all these things. Okay. I have projected the picture of this anatomy of nasopharynx, which I already put it there. So now you can understand it once again. So it is so you could see below the body of sphenoid at this level. If you can see, the body of sphenoid is there over here, and on either side is the inferolateral deficiency, which is there present in the eustachian tube orifice. This is the posterior wall of the nasopharynx. This is the posterior wall of the nasopharynx. Draw a line like this. Draw an ulta line like this. This becomes the nasopharynx. So below the body of the sphenoid, it will be there. As you could see, here will be your spinobacillar synchondrosis. Spinobacillar synchondrosis. So sphenoid bone and occipital bone, they join together, they form spinobacillar synchondrosis. At that junction, you can find the pseudostratified ciliated columnar epithelium. Pseudostratified ciliated columnar epithelium, which when you go down and down, it becomes a stratified squamous epithelium. So pseudostratified ciliated columnar epithelium is a respiratory epithelium, and stratified squamous epithelium is like a aerodigestive tract, that is especially digestive tract epithelium. Okay, digestive tract epithelium. You will find the eustachian tube over here. So eustachian tube, if you take like this, there is an elevation called as torus tubaris over here. This is called as torus tubaris, as you could see here. And the one which is there medial to it, and then which is having like a fissure here, like a fossa. I'm sorry, a fossa. This is just like something called as fossa of Rosenmuller. What is this called as? Fossa of Rosenmuller. Fossa of Rosenmuller. Fossa of Rosenmuller. Very important. Why this fossa of Rosenmuller is important? Fossa of Rosenmuller is a site for nasopharyngeal carcinoma, which we are going to discuss today. So nasopharyngeal carcinoma most commonly is there in the fossa of Rosenmuller region. Okay. If you take, this is the eustachian tube, this is the eustachian tube. Here will be the fossa of Rosenmuller, something like that. So when you go, as you see, like this particular nasopharynx is going to open down. This is just as in front of the second and third cervical vertebrae, and it is going to open down towards the laryngopharynx here. Laryngopharynx. On the sides of this nasopharynx, superiorly is your eustachian tube, and inferiorly will be your this parapharyngeal space here, and the superior constrictor muscle here. So this is the superior constrictor muscle, and below it will be the middle constrictor, and below it will be the inferior constrictor. So this is the parapharyngeal space. What are there in the parapharyngeal space? 9, 10, 11, 12 cranial nerves coming from the skull base, carotid sheath, that is CC10 IJV from medial to lateral, and sympathetic plexus. Sympathetic plexus, which causes Horner syndrome if anything is done for it. Horner syndrome. Okay. And then you have got the layers of this nasopharynx. If you take, you have got mucosa pharyngobacillar fascia. Remember, from mucosa, M for M. Remember, P for pharyngobacillar fascia. Member of Parliament, you remember like that. Mucosa pharyngobacillar fascia. This is muscle layer. Muscle layer. What is the muscle layer? Superior constrictor, middle constrictor, and inferior constrictor. Superior constrictor and middle constrictor, they help in the formation of your nasopharynx, posterior wall. Okay, and oropharynx. And this is oropharynx, and then below it will be the inferior constrictor, which is related to hypopharynx. Inferior constrictor is related to hypopharynx. So that is a different issue. So this is the muscle layer. So member of Parliament, muscle layer, this is a mucosa, pharyngobacillar fascia, muscular layer, and buccopharyngeal fascia. The next layer will be buccopharyngeal fascia. Buccopharyngeal fascia. And the last layer will be prevertebral fascia in front of the atlas and axis, as we have seen. The level 1 will be for nasopharynx, level 2 will be for oropharynx, level 3 will be for oropharynx. This 2 and 3 vertebrae related to oropharynx. Okay, 4, 5, 6 vertebrae related to hypopharynx. 4, 5, 6 vertebrae related to hypopharynx, as you could see here. So as you could see once again, so anatomy of nasopharynx, if you can take, cannot be palpable. Cannot be palpable. This is one point. And second thing is retropharyngeal lymph nodes. So they cause something called as neck rigidity. So if these are involved, these are the clinical points which you should be knowing when you are talking about this nasopharyngeal carcinoma. So I am just closing up this slide share, and once again I want to go for some other slide share about this nasopharyngeal carcinoma. Hello.
Yes, sir.
Are you able to see the share screen?
Yes, sir.
Yes, sir.
Yeah. Welcome to Jayachandra Chanakya. Okay. So nasopharyngeal carcinoma is very important as far as the exam point of view is considered. We have dealt about the nasopharyngeal angiofibroma, is it or not? So we have dealt about the nasopharyngeal angiofibroma. So NP nasopharyngeal angiofibroma. Just a moment. So you could see the nasopharyngeal carcinoma here. Previously we have seen NPF, nasopharyngeal angiofibroma, which is very important. Juvenile nasopharyngeal angiofibroma, which is one of the benign but having infiltrating potential. So infiltrating potential. Okay. But this is a carcinoma itself directly. Okay. Carcinoma itself directly, which is very important, especially in the Chinese population. Now we are dealing with the China virus. This is the Chinese population which are associated with Epstein-Barr virus. Okay, previously known, especially southern China, Taiwan, southern China and Taiwan, and Indonesia. So very much prevalent over there. Those Chinese who are settled in America, they have got lesser amount of disease, but that is more than the Native Americans. So it is a Chinese disease, as you can remember, like that. And then even in India also, especially the northeast, where the people are from Mongoloid race, Mongoloid origin, like Assamese, etc., Mongoloid related things, the nasopharyngeal carcinoma is very important. So in those people, it is very much like prevalent disease. So India, even then also prevalence in India is very less. So it is very less, especially in China only it is higher. Okay, American Chinese also it is very less, but Chinese origin is very important. So as you could see that 85% of the nasopharyngeal malignancies are carcinoma. Adult nasopharyngeal malignancies are carcinomas. 85% they are carcinomas. Whereas in pediatrics, in children, the common things are rhabdomyosarcoma, that is related to muscle, rhabdomyosarcoma. Number 2 is lymphoma. Rhabdomyosarcoma and lymphoma. You can understand rhabdomyosarcoma and lymphoma. Whereas 30% of pediatric nasopharyngeal malignancies are carcinoma. So more common in children is rhabdomyosarcomas. In adults, it is carcinomas only. Of course, nasopharyngeal carcinomas only. Children, it is rhabdomyosarcoma and lymphoma. More in Chinese and North Africans, as I already told you, male preponderance. Males are more, like in the JNA, males are more. And it has a small peak and a large peak. That is, even young people are also having this disease sometimes. Small peak and large peak. Small peak, that is biphasic distribution, bimodal distribution. 50 to 60 years more common. Even in youngsters also you can see this. Grossly, if you see, it looks like a proliferative thing, like a cauliflower growth, or ulcerative thing which is functions like an ulcer, or infiltrative thing which goes inside which goes towards inside the basement membrane and then goes inside and spread rapidly. Infiltrative one is more dangerous, of course. Histologically, if you classify, so most of the head and neck cancers are squamous cell carcinomas. So histologically, if we classify, they are 85% squamous cell carcinomas. I told you what is the lining epithelium is non-keratinized stratified squamous epithelium. Squamous epithelium will give only most commonly squamous cell carcinoma. Okay, and 10% of them are lymphomas and 5% are mixed. So lymphomas, why? Because Waldeyer's ring is present. Waldeyer's ring is present, therefore they are called as lymphomas. Okay, more common associated with them is the lymphomas. When you take up the etiology, so the genetic is the commonest in Chinese population. It is commonest in Chinese population. It is more common in Chinese population. So any of the cancers has got genetic factors, number one, number two, environmental factor. GE, you should remember, genetic factor, environmental factor. Okay, genetics, especially HLA-A2, HLA-BS in BS-IN2 is histocompatibility locus. HLA-A2 and HLA-BS-IN2 is histocompatibility locus. Important, of course. You can mark it down. Viral Epstein-Barr virus, as I told you already, Epstein-Barr virus especially is having two things. So number one is early antigen and viral capsid antigen. Early antigen is specific for diagnosis. Viral capsid antigen is sensitive for diagnosis. If Epstein-Barr virus is associated with the NPC, you will have good radiotherapy prognosis. Prognosis for radiotherapy is very good. You should consider over here. Epstein-Barr virus, prognosis for radiotherapy is very good. To take environmental, the exposure to nitrosamines, dry salted fish. Okay. So they say Endosapa, which is with Upu Endosapa, in our region we call it as, okay. Dry and salted fish. Because of the nitrosamines, okay. Especially vitamin C block these nitrosamines, which is very good for this prevention of this carcinoma. So these nitrosamines are inhibited by vitamin C. So vitamin C is very important. It will help in prevention of the cancer. Okay. And polycyclic aromatic hydrocarbons. So whatever we give, okay, Ambika Darbar Bhatti, those bhattis we just try to give it for offer for the god. Okay. And burning of the wood also. So smoking from incense sticks like agarbattis and wood. So nitrosamines are there. Don't get exposed too much. Of course, very dangerous. That is leading to nasopharyngeal carcinomas. Okay. Of course, you know, smoking is there. It is always a factor. And poor ventilation of the nasopharynx and chronic nasal infections. Any infection can lead to that. Chronic nasal infection also can lead to that. When you take a classification done by W.H.O, so what you have to see here is type 1. Almost 25% is type 1. You should have it in mind. It is given in your textbook also. Squamous cell carcinoma. What is it? What is there in that squamous cell carcinoma? Squamous is something related to skin, non-keratinized stratified squamous epithelium. More commonly, squamous cell carcinoma, keratinized. Okay. When you say keratinized, you get non-keratinized variety. Okay. When you get non-keratinized variety, you can have classification like non-keratinizing, and in that only it is classified as undifferentiated. Of course, the classification is somehow complicated and then somehow it is confusing as far as pathology is concerned. So when we do non-keratinizing, so type 2, type 3. So type 2 and type 3 are non-keratinizing varieties. Type 1 is keratinizing, that is squamous cell carcinoma 25%, and then type 2 is 12%, and type 3 is the most common, that is 67%. Whatever is remaining, 67%. So 12% and 67%, 25%, 12% and 67%. So most commonly is type 3. Type 3 is most common, that is 67%. So when you have without lymphoid stroma with lymphoid stroma, once again, without lymphoid stroma with lymphoid stroma. So when you have it a non-keratinized, it can be a differentiated one and undifferentiated one. So differentiated, it resembles the parent epithelium. Without lymphoid stroma with lymphoid stroma. Without lymphoid stroma is intermediate cell. With lymphoid stroma is a clear lymphoepithelial cell. Undifferentiated type, in this undifferentiated type, which is the worst type, which can be called as anaplastic. Anaplastic doesn't resemble the parents. Anaplastic doesn't resemble the parents. So differentiation is related to the parent epithelium. When a cancer is coming and then it is relating to the parent, it is a good one. When a cancer is coming and it is relating to the production epithelium, parent epithelium is not so. It's like Panditaputra Paramasonta. It can be called as undifferentiated variety or anaplastic variety. It is the worst thing. Of which without lymphoid stroma and with lymphoid stroma. Without lymphoid stroma, it can be called as clear cell cancer. With lymphoid stroma is lymphoepithelial. It can be called as lymphoepithelial with lymphoid stroma. Okay. So of which you have to remember, number one is keratinizing, number two is non-keratinizing undifferentiated, non-keratinizing differentiated, non-keratinizing undifferentiated. Number three is NKUD undifferentiated. Undifferentiated is the worst thing that can happen. It is anaplastic, as I already told you. So it is classified previously as a different terminal that is given in your book. So non-keratinizing, it can be non-keratinizing, it can be like transitional cell carcinoma, intermediate cell carcinoma, and lymphoepithelial carcinoma of Regard type. Regard type, REGAUD, Regard type. Okay, anyhow, we are not going to go into the details of it once again. So with lymphoepithelial carcinoma of Regard type. So this one is called a Regard, REGAUD. It is given in your book. You don't need to worry. It's Regard type. And then anaplastic carcinoma, anyhow, it is there. I already told you. Clear cell carcinoma can be there with lymphoid stroma. And lymphoepithelial of non-keratinizing can be called a Schminke type. Lymphoepithelial, this is called a Schminke, SCHMINKE, Schminke's type. The names that are given in the textbook. Of course, not worry much about these things. This is a pathologist's job. You have to understand and then keep in mind. If you are able to remember, it's okay. If not, it's not an issue. Okay. This is Regard type and this is Schminke's type. Regard's type and Schminke's type. What are the clinical features? Especially nasopharynx is richly supplied with lymphatics, especially when you have got lymphatics supplied towards level 2 and then lymphatics supplied towards the retropharyngeal nodes and lymphatics supplied towards the host triangle, something called as host triangle. What is host triangle? If you take this is the clavicle, if you take this is the neck, okay, this is the trapezius. So medial end of the clavicle, lateral end of the clavicle, and wherever the neck meets the shoulder. This particular thing is called a host triangle. This is called as host triangle. If host triangle node is involved, it is definitely N3, whatever is the size. N3, it is having bad prognosis. It is definitely N3. You should keep it in mind. Definitely N3. Okay, when host triangle is involved. So neck swelling is the commonest presentation. The patient presents with the neck swelling. There is a lymphadenopathy, bilateral, enlarged upper, middle, and deep cervical nodes plus posterior triangle nodes. This is called as Rovier's sign. What is it called as? Rovier's sign. So posterior triangle nodes called as Rovier's sign. As you can keep it in mind, Rovier's sign. These are the neck swelling present. Most commonly, 90% of the patients present with neck swelling. Number two, nasal complaints, like because it is a nasopharyngeal growth, epistaxis, nasal block, nasal discharge. Because the nasopharynx is obstructed, it leads to something called as rhinolalia clausa. Rhinolalia clausa. So when you close your nose and talk, it is called as rhinolalia clausa. So rhinolalia clausa. Rhinolalia clausa. And otological complaints. This is very important. Why? Because a unilateral nasopharyngeal block associated with conductive deafness should always suspect a growth in the nasopharynx. Always suspect a growth in the nasopharynx. So that can be called as a conductive deafness that is occurring over there. Conductive deafness that is occurring over there along with tinnitus, because eustachian tube block is also one of the reason for tinnitus. Eustachian tube block is also one of the reason for tinnitus. And other clinical features like ophthalmological. So ophthalmological very important because diplopia, number one, ophthalmoplegia. Most commonest cranial nerve involved is sixth cranial nerve. You should have it in mind that sixth cranial nerve is the commonest cranial nerve that is involved. Sixth cranial nerve is the commonest cranial nerve involved in the, and is also the cranial nerve which is having the longest intracranial course. Cranial nerve having the longest intracranial course. Sixth cranial nerve. Okay, false localizing sites are more common in this. And you have got involvement of third, fourth, and sixth cranial nerve. Sixth cranial nerve, lateral rectus. SO4, LR6, lateral rectus. Is it or lateral rectus is involved? Okay. So that is leading to diplopia. And proptosis because of orbital invasion. Proptosis can be there because of orbital invasion. Maybe it is from below the inferior orbital fissure or superior orbital fissure or optic canal. So orbit can be invaded by inferior, superior, optic canal. Blindness can be there because of the involvement of second cranial nerve. Blindness can be there because of the involvement of second cranial nerve. You should keep it in mind. What are the neurological complaints possible? Jugular foramen syndrome. I call it as Jaffa syndrome for remembrance. Jaffa syndrome, jugular foramen syndrome. You can just remember it with 9, 10, and 11 cranial nerves are involved by lateral retropharyngeal lymph node. So the retropharyngeal lymph nodes are named as Krause and Wolfring. K-R-A-U-S-E, Krause and Wolfring. W-O-L-F-R-I-N-G, Wolfring. Okay. Retropharyngeal space, the lymph nodes are named as Krause and Wolfring. When they are involved, it leads to something called a jugular foramen syndrome. Directly or indirectly, parapharyngeal space, if it is involved, it can also lead to retropharyngeal. That is the 9, 10, 11, 12 cranial nerves can be involved in involvement of parapharyngeal space also. During the involvement of parapharyngeal space also, it can be there like that. As I already told you about this Horner syndrome, there can be sympathetic chain involvement. So 9, 10, 11, 12 cranial nerves, 9, 10, 11, 12 cranial nerves along with sympathetic chain. Sympathetic chain is very important. Ptosis, meiosis, anhydrosis, and ophthalmos all will be there along with Horner syndrome. There can be severe headache with skull base erosion. Skull base erosion. So what is Trotter's triad? Very important for our UG exam is Trotter's triad. Ipsilateral temporoparietal neuralgia. Ipsilateral temporoparietal neuralgia. Ipsilateral parietal paralysis and conductive deafness. And conductive deafness. And conductive deafness. I told you conductive deafness is because of eustachian tube block. Remember, conductive deafness. Temporoparietal neuralgia is because of fifth cranial nerve involvement. Okay, fifth cranial nerve involvement is temporoparietal nerve neuralgia. Fifth cranial nerve involvement is temporoparietal neuralgia. Temporoparietal neuralgia is fifth cranial nerve involvement. Okay. And ipsilateral parietal paralysis. Parietal paralysis is 10th cranial nerve involvement. Remember, 5 is involved, 10 is involved, and eustachian tube block. That is what is Trotter's triad. It is very important for 2 marks. Trotter's triad is very important for 2 marks. Please note it down. Everybody should answer this. Trotter's triad is ipsilateral temporoparietal neuralgia, parietal paralysis, and eustachian tube block. And distant metastasis, always remember LLB. Distant metastasis for liver, lung, and bone. Always remember for three things. So here you could see the neck swelling in the posterior triangle. Yes. And you could see the ptosis and adduction paralysis. Okay, ptosis is because of a third cranial nerve involvement, and adduction paralysis. So all these things are because of cranial nerve 3, 4, 6. As you could see, 3, 4, 6 involvement can cause all these things. So as you could see the ptosis over here, left ptosis over here. So how is the spread of this particular NPC occurring? Spread of this particular NPC occurring means, so when eustachian tube is involved, as you could see here, it causes cilious arteritis media. This is also from a textbook only directly. Nose and orbit are involved. It can lead to nasal block, epistaxis, and proptosis. Nasal block, epistaxis, and proptosis. Distant metastasis, I already told you, liver, lung and bone, LLB, liver, lung and bone. Okay. Cervical lymph node enlargement is there, upper jugular, posterior triangle, node involvement. I already told you, posterior triangle nothing but, and also inferior supraclavicular triangle called host triangle, as you could see here. Cranial palsy like 9, 10, 11, 12, all 9, 11, 12, lower cranial paralysis and Horner syndrome, all leading to this because of parapharyngeal space involvement directly or retropharyngeal space involvement indirectly. Okay. And retropharyngeal node involvement, as I already told you, it leads to neck pain and stiffness. Stiffness and neck pain is there. Pterygoid muscles, if they are involved, it leads to trismus. Pterygoid muscles are present in the infratemporal fossa. Where is the infratemporal fossa? Just below the middle cranial fossa. Infratemporal fossa is just below the middle cranial fossa. Infratemporal fossa is just below the middle cranial fossa. Okay. So if you take this is the middle cranial fossa, below it will be your infratemporal fossa. The spread can be occurring anywhere to anywhere. You should remember that. And you have this foramen lacerum and ovale. Foramen lacerum has got no contents. Of course, it is just present posterolateral to the. It is a posterolateral boundary towards the fossa of Rosenmuller. When you go from fossa of Rosenmuller posterolaterally, you reach the foramen lacerum. And as you could see in the skull base, if you try to see in the middle cranial fossa itself, in this region, the lacerum will be here, ovale will be here, and spinosum will be here. From medial to lateral, it is lacerum, ovale, and spinosum. Okay, medial to lateral, it is lacerum, ovale, and spinosum. As you could see, ovale is mandibular division of the trigeminal nerve, axillary meningeal artery, lesser pectoral nerve, and emissary vein is ovale. Okay, lacerum now passes through this, but below the lacerum will be the carotid artery. Below the lacerum will be the carotid artery. And spinosum, as you know, that is middle meningeal artery. Spinosum is middle meningeal artery. Foramen spinosum is middle meningeal artery. So when it passes through that, it can cause ophthalmological symptoms like 3, 4, 5, and 6 involvement slowly. Okay, all these can be involved. Next, investigations. So what is the spread of this particular this tumor? You should be able to know it. Okay. There can be proliferative type, ulcerative type, infiltrative type. That is also given in the textbook. And when it involves the fossa of Rosenmuller, posterolaterally it goes towards the carotid artery. As you could see, anteriorly it could go towards the nasal cavity. Anteriorly, when it goes towards the nasal cavity. Anteriorly, it can go to the nasal cavity. Inferiorly to the oropharynx and hypopharynx. When you have to see that, inferiorly it goes to the oropharynx and hypopharynx. Just I am taking a line to draw this here. For example, anteriorly it comes towards the nose. Okay. Superiorly it goes to the skull base. Okay. As you could see. And laterally when it goes, so for example, here is the eustachian tube over here. This is the fossa of Rosenmuller. So laterally if it goes means, I told you in the this one. So here will be your superior constrictor muscle. Okay. This is a eustachian tube. This is a superior constrictor muscle. So when it goes laterally like this, it goes to the parapharyngeal space. Okay. Parapharyngeal space involving the 9, 10, 11, 12 cranial nerves. Okay. When it goes superiorly and then it goes behind. For example, it goes towards the vertebrae. It can go towards the vertebrae. It can pierce the prevertebral fascia, and it can go towards the sinus of Morgagni. Sinus of Morgagni. That is at the base of the skull. Sinus of Morgagni is at the base of the skull. You should have it in mind. Okay. And towards the intracranial structures. And as I told you, foramen lacerum and ovale and spinosum, they help in the spread towards the middle cranial fossa. Just I am taking drawing to draw the space. This is not related to the picture behind. Okay. So middle cranial fossa is go towards foramen lacerum, ovale, and spinosum. I already told you this one. Okay. Sixth cranial nerve is the first one to be involved. Very important point to remember. This sixth cranial nerve is the first one to be involved. And then spread along the posterior skull base, as I told you, 9, 10, 11, 12 cranial nerves and sympathetic plexus. All these can be involved. And then once again, if laterally if it is spreading means infratemporal fossa, it can lead to trismus. Okay. Trismus. Why? Because of involvement of muscles of mastication. So spread can be anywhere. By understanding the skull base anatomy, you can know how it is going to spread and how it is going to cause all those things. So that is very important. And investigations, if you take, we do the diagnostic nasal endoscopy, that is called as D.N.E, diagnostic nasal endoscopy. Yes or no? So D.N.E we do already in the department itself. We have seen a lot of times. We've seen a lot of times. It is called as diagnostic nasal endoscopy. It is called as D.N.E. Okay, D.N.E endoscopy, diagnostic nasal endoscopy. Or else you go over nasopharyngoscopy. To see the nasopharynx, you use nasopharyngoscopy. Very simple. Nothing much to remember in this. Tumor mass is seen in the nasopharynx, and commonest site is, as I already told you, fossa of Rosenmuller. Fossa of Rosenmuller. Biopsy can be done, of course. In juvenile nasopharyngeal angiofibroma, biopsy is contraindicated. But in nasopharyngeal cancer, you can go for biopsy. Sometimes, if you don't find the tumor, you have to go for blind biopsies. Where do you go for blind biopsies? You go at the tongue base, number one, tongue base. Under G, you go for tongue base, and tonsil fossa, you go for this one, and also nasopharynx. Blind biopsy, whenever you don't find any primary tumor not found in the neck, but you have got the lymphadenopathy, lymph nodes are enlarged. For example, lymph nodes are enlarged, tumor is not found, you go for something called as blind biopsy. What is blind biopsy? You go in that situation. FNAC of the neck node in occult primary. Occult is not seen primary in the last 5 years. Okay, primary not seen in the last 5 years, that is called as occult primary. That is not seen in the 5 years is called as occult primary. CT scan of the head and neck, of course, you go for CECT, contrast enhanced CT scan for the neck. So for tumor extent, skull base erosion, and cervical lymph node metastasis, all these things you have to confirm in CT scan. Other investigations you want to do is M.R.I. head and neck for intracranial extension. For intracranial structures, intracranial extension, I call it as ICE. Intracranial extension, you go for M.R.I. head and neck. Okay. Test for metastasis. What is that? Whether the metastasis has occurred or not, how do you know? CT scan chest is important, very important. CT scan abdomen is important for metastasis. Can go for bone scan. Nowadays, most importantly is the PET scan. Very important. PET scan is being done, and LFT. Whether liver is involved or not, you can go for LFT. Okay, liver is involved or not, you can go for LFTs. What are the serological tests that you want to do? Is I already told you immunoglobulin A, IgA, for viral capsid antigen. Okay, and early antigen. So early antigen is specific. Viral capsid antigen is sensitive. Okay, I already told you viral capsid antigen is sensitive, early antigen is specific. Okay, so cell dependent cytotoxicity, SC also you can go for it. On nasopharynx, you can see here. Okay, this is a posterior endoscopy picture. Of course, this is the Eustachian tube which I was showing you here, and this one will become the fossa of Rosenmuller. Fossa of Rosenmuller here. You could see a growth in the vault of the nasopharynx. Okay. So this is the tubal orifice, as you could see, inferior lateral deficiency. Here is the tubal orifice, of course not seen properly. And CT scan, if you see, you can see it here in the nasopharyngeal region. Nasopharyngeal region, you could see a particular tumor over there. So retropharyngeal lymph nodes, if the lymph nodes are involved, retropharyngeal space, you can find something over here. So orbital extension, I told you in the orbit, it can go at orbital apex, or it can go to the infraorbital fissure, inferior orbital fissure or superior orbital fissure. Anything can get involved. So these are all pictures as an example. That's it. Okay. Cellular involvement, they can go spread superiorly, and it can involve the sphenoid sinus and sella turcica. Sphenoid sinus and sella turcica also. Okay. They involve like that. And MR imaging, as you could see here, the density over here. MR invasion in the parapharyngeal space involvement. So parapharyngeal space, as you could see here at this region. Neck node metastasis, you could see the nodal metastasis in MRI. Intracranial extension, I told you ICE, intracranial extension. This can be the intracranial extension. When you are taking the biopsy, whichever true cut forceps, biopsy with through cut. Okay, THROUGH through cut. Biopsy through cut. And metastasis in the liver, as you could see over here. Whole body bone scan, I told you bone scan So uptake is more for that particular wherever there are tumor cells. And PET scan, so it is based on FDG, fluorodeoxyglucose. It will be coming up in the coming days. Fluorodeoxyglucose uptake is more by the cancer cells because they need a lot of glucose. With PET scan, there is enhancement, hotspots over there. How do you stage the tumor? Important. T1 is for the nasopharynx only. T2 is coming down oropharynx or nasal cavity or parapharyngeal space. Okay. So T1 is nasopharynx, T2 is oropharynx, nasal cavity or parapharyngeal space. Okay. T3 is bony structures. T3 is bone involvement or paranasal sinuses. T3 is paranasal sinuses. So this is parapharyngeal space, this is paranasal sinuses. T4 is intracranial extension, as I already told you, intracranial extension or orbit or nerves, cranial nerves or infratemporal fossa or hypopharynx. If hypopharynx comes last, here is the oropharynx, but hypopharynx is coming last like this. Okay, hypopharynx is here, very important. Hypopharynx, nerves, this is the nerves and this is the infratemporal fossa and hypopharynx and orbit. All important structures are named as almost intracranial, orbit, cranial nerves, infratemporal fossa and hypopharynx. Hypopharynx is placed in the T4. N0, no evidence of lymph nodes. N1 unilateral, N2 bilateral. Okay, both are above the supraclavicular fossa. So if you take the clavicle, it becomes a landmark in the nasopharynx. Other tumors, it is very different. Thyroid and then this nasopharynx have got different classifications, except all the things are the same. I'll tell you in the coming classes whenever you are going to see the oncology of the other part of the head and neck. Okay. So supraclavicular fossa, as I already told you, it is called as host triangle. So host triangle is already I told you as host triangle. Supraclavicular fossa is host triangle. So N1 is unilateral, N2 is bilateral. N1 and N2 both are above the supraclavicular fossa. So as you go up and up, they are not important in nasopharynx. The upper level nodes like level 2 nodes and level 3 nodes are not very important, whereas lower level nodes like level 4 nodes and level 5 nodes are very important because these are nearer to the clavicle, supraclavicular, especially level 5. Okay, this is along the sternocleidomastoid. I'm telling, this is along the sternocleidomastoid will be these nodes, and especially this 5 will be above the clavicle. This is supraclavicular nodes. Okay, very important here. So above the supraclavicular fossa less than 6 centimeters, N1 and N2. N3 is nothing but more than 6 centimeters in the supraclavicular fossa. N3 more than 6 centimeters. All others the classification is different. Whereas you have to by heart this one. So N3 is more than 6 in supraclavicular fossa. Okay, N3 is more than 6 in supraclavicular fossa in nasopharyngeal carcinoma. You have to remember this. You have to write it down on paper and stick it in your rooms so that you can remember as easily as possible. That is the way you have to learn this, by heart these things. Okay, keep on seeing them daily. M0 is no evidence of nodes, no evidence of distant metastasis. M1 is evidence of distant metastasis like liver, lung and bone. I already told you. So supraclavicular fossa, as I already told you, host triangle. So medial end of the clavicle, lateral end of the clavicle over here. And nape of the neck, if you take, so medial end of the where the neck joins the shoulder. This is the point where neck joins the shoulder. This is called a supraclavicular host triangle. Supraclavicular or host triangle. Medial end of the clavicle, lateral end of the clavicle, junction between neck and shoulder. Host triangle, very important. Irrespective of the node status, it becomes N3 if the host triangle is involved. You can see here N3 supraclavicular, very important. It becomes the host triangle, and it will become the N3 greater than 6 centimeters, greater than 6 centimeters, greater than 6 centimeters. Okay. So staging, group staging. This at the end of the day, I will put some video, and then you can see that how to stage this. Stage 1 is T100. Okay. Stage 2 is 20, T2 N1 M0. Okay. Stage 3 is T3 N2 M0. Stage 4 T4 or N3 M1. So this is how very simple. You can just remember and try to tell. Like you have a table like this. So N1, N2, N3. Previously itself I told T1, T2, T3, T4 you will be having, and then as you could see 1, 2, 3, 4. Okay, 3, 3, all 4s. These are all will be 4s. Okay, so these all become stage 4. So T1, N1 will become stage 1. Okay, N0 will become N0, N1, N2. Like this, you have to do N2, N3. Okay, so you have to draw it like this. I'll tell you a table at the end of the day. You can just use it for all the particular stagings. What are the differential diagnosis possible? Differential diagnosis are JNA, juvenile nasopharyngeal angiofibroma, which we already dealt it, and rhabdomyosarcoma. I told you in children, it is very common. In child, you have to take care of the differential diagnosis, and lymphoma is very important because of Waldeyer's ring. Because of Waldeyer's ring. Okay, Waldeyer's ring is there, therefore you should keep it in mind. Treatment modalities, especially radiotherapy, is the treatment of choice for nasopharyngeal carcinoma. Radiotherapy is the treatment of choice for nasopharyngeal carcinoma. It is called as teletherapy. You are putting some beams from outside. It is called as teletherapy or external beam radiotherapy. It is also called as external beam radiotherapy. External beam radiotherapy, EBR. It is called as external beam radiotherapy. Next, brachytherapy. You are putting implants inside the cavity itself, inside the tumor itself. It is called a brachytherapy, like iridium 192. You have to put iridium 192. You will put iridium 192. Iridium 192. Chemotherapy with 5-fluorouracil and cisplatin. 5-fluorouracil, cisplatin. These are the things that you give for the chemotherapy. Next, surgery like nasopharyngectomy. It is called as nasopharyngectomy. It can be done with endoscope. Number 1, endoscopically you can do it, or you can do it open procedures also. You can do it with open procedures like leaf-fold osteotomies. Immunotherapy against Epstein-Barr virus is one more trial, and vaccination against Epstein-Barr virus is experimental still. All the vaccines like corona vaccine are not effective by date. Okay. So cobalt teletherapy. So teletherapy is like you put on patient here and send the rays like this. This is a radiation oncology specialty. Send the rays like this. Cobalt therapy. Cobalt 60. It is called as cobalt 60. You will be using something called a linear accelerator. It is called a LINAC, linear accelerator. Nowadays, latest trend is to use LINAC, linear accelerator. External beam irradiation. So you have to go for lateral fields and anterior fields. You have to protect the nose, and then you have to protect the parotids, etc. You have to protect the eyes, but you go for striking the nasopharynx only, sparing the temporal lobe, pituitary and spinal cord. All these things should be protected. You have to go for only nasopharynx. The field, the radiation should go to the nasopharynx only and skull base only. So one anterior, 2 lateral fields and 1 anterior field, that is especially in the lower neck, sparing the spinal cord and larynx. All the important structures should be spared. Brachytherapy is used for small tumor and residual tumor and recurrent tumor. Whatever is left out after surgery or recurrent once again is coming, you have to go for brachytherapy. Brachytherapy, as you could see here. Interstitial brachytherapy, that is a radioactive source. So it's like radium, iridium, which I already told you, iodine or gold. Okay, gold 198 is also used. Gold pellets they paste. Gold pellets, they call it as gold pellets. Gold pellet therapy in the tumor tissue, into the tumor tissue. Intracavitary is that is interstitial. This is intracavitary, wherein you have to go for radioactive source placed inside the catheter. You will be putting it inside the catheter or mold and insert into the nasopharynx. That is intracavitary. High dose rate. What is HDR? High intensity radiation under computer guidance you will be putting. So interstitial brachytherapy, as we have seen, intracavitary, interstitial, okay, high dose radiation. These are 3 types of radiation that are present. So brachytherapy, you are putting placing the crystals over there, intracavitary. So intracavitary, you are putting a catheter. This is a catheter, and then you are inserting into that the radiation related substance. High dose rate brachytherapy, HDR brachytherapy. Brachy means you are putting inside the cavity. Inside the cavity. Brachy means you are putting inside the cavity. It is called as brachytherapy. Brachytherapy is you are putting something inside the cancer. And what is the chemotherapy that is being used? I told you already, cisplatin and 5-fluorouracil. It is useful in radiation failure and palliation and distant, especially chemotherapy is used for distant metastasis. Distant metastasis. What are surgeries possible for this nasopharynx is nasopharyngectomy. I already told you. Cryosurgery can be there. Okay, cryosurgery uses cold. Okay, cryosurgery uses cold, especially there's nitric oxide, nitrogen gas that can be used It is freezing and thawing. It is called as freezing and thawing. So freezing and thawing for residual and recurrent tumor. This is not very important, of course, though. And for neck, if there are neck nodes, not only you treat the nasopharynx, you have to go for radical neck dissection. If they are radio resistant, lymph node metastasis. They are radiation resistant, you have to remove all the neck nodes. You have to remove all the neck nodes along with sternocleidomastoid muscle, okay, and spinal axillary nerve, that is spinal axillary nerve, and internal jugular vein. Okay, internal jugular vein. These are the three things that are removed in neck dissection. We will be discussing a topic on neck dissection if possible. Okay, so neck dissection, you remove the sternocleidomastoid muscle, spinal axillary nerve, internal jugular vein, and other nodes, possible nodes. Okay, 1, 2, 3, 4, 5 level nodes. 1, 2, 3, 4, 5 nodes. Okay, all these things you will be removing. Palliative debulking for T4 tumors. Okay, palliative debulking. You have to debulk the tumors for palliation only. You cannot. What is palliative therapy? You are just giving a cure. You are just giving a healing, but not cure. Okay, you're not curing it completely. Just a small amount of healing that you are giving with the help of surgery. Okay. Next, myringotomy and grommet for otitis media with effusion. For otitis media with effusion, what you are supposed to do? Myringotomy with grommet insertion. It is a regular surgery which you do. So radical neck disease dissection, or you are removing the specimen. All I told you. So sternocleidomastoid is removed. Okay, internal jugular vein is removed, and okay, and that spinal axillary nerve is also removed. Okay, along with that other lymphatic structure. And then later on you go for interstitial brachytherapy. I told you interstitial brachytherapy. So in between the tissues you are putting interstitial brachytherapy. Treatment protocol. For T1 lesions, radiotherapy is enough. What is the treatment of choice for nasopharyngeal carcinoma? You should say radiotherapy is enough. T2, radiotherapy external higher. Centigrade. Gray is the unit for radiation. Okay, gray is the unit for radiation. 6500 centigrade is the treatment of choice. T3 and T4, you go for radiotherapy and chemotherapy. You are increasing the stage, that is T3, T4. Radiotherapy and chemotherapy. You might have to go for brachytherapy or salvage surgery if required. Brachytherapy or salvage surgery if required. For N0, external radiotherapy for 5000 centigrade. That is, these are the nodes. These are the T staging, and this is the nodal staging. T staging and nodal staging. When you have to do that, you have to go for this particular treatment. Just a moment. So end staging, so end staging you have to go for external radiation. If N0 is there, N1, N2, N3, you have to go for radiotherapy and chemotherapy. As the stage progresses, it becomes worse and worse. You have to increase all the treatment modalities. That is the common sense. WHO type 2 and type 3, as I told you, they are non-keratinized carcinoma, has good response to radiotherapy and better survival rates. Okay, good response to radiotherapy, and these are WHO type 1 and type 2. As I already told you, type 1 and type 2 are non-keratinized, undifferentiated, differentiated. Okay, differentiated and undifferentiated. These are two types that are present over there. They are having better survival rates, like stage 1 95, stage 2 60, 30 and 20. They are having decreased as you go forward. This is how we have to go for the understanding of nasopharyngeal carcinoma. So once you go for this nasopharyngeal carcinoma, you have to know all these things, varieties, and spread is important, host triangle is important, and then ipsilateral temporoperitoneal, that is Ptosis triad, is important, and the staging is important, and then how do you treat is important, how is the spread is important, and then all the terminology related to that, keratinized and non-keratinized, keratinized, non-keratinized, wherein undifferentiated and differentiated. Okay, all these things are there in your book. You can understand it very easily. Before that, you have to understand this particular anatomy of this nasopharynx. That's why I spread. I have done that so that you can understand it in a better manner. Hello. Hello.
Yes, sir.
Yeah. I hope you are having a fair understanding of this nasopharyngeal angiofibroma and carcinoma. And then next classes we will go for this as a whole. This cancer will be completing whatever is there for your syllabus. Most importantly, nose we have completed, nasopharynx we have completed. You have to go for larynx. You have to go for oral cavity, oropharynx. All those things will be covered slowly one by one. one after the other, so that you will be having a fair idea of this second important part of this ENT called as head and neck surgery. Okay, I think this marks the end of the class. Any doubts are there, you can just